Perfect. Thank you. Thank you. And we are recording this session for future users. Thank you so much, Samantha. See if I can advance. Wonderful. So you can see here all our speakers and in some ways contributors to today's session. I will be followed by my presentation will be followed by Ross Glasgow, then Dr. Katie Trinkley. Meredith Fort is a wonderful contributor to this work, so we wanted to acknowledge her. She's not here today, and she's not going to speak. Samantha Harden will take over then. And as I mentioned, Paul is going to be our facilitator and discussant for today's session. Thank you so much. You can see our affiliations here, and feel free to reach out after the session if you have questions as well. Today's session will include a number of topics. As I mentioned earlier, they will be addressed in a rapid fire method. We will be sharing with you some new developments. We will share with you some opportunities to interact with us around PRISM, but we will not get into the great depth of these topics. I will start by providing just a brief reminder what PRISM is and how it's connected to REAIM, and then share with you some findings from a recent PRISM systematic review that we completed, just got published a few weeks ago. Then I will hand it over to Russ, who will talk a little bit about the health equity aspects of PRISM, and then Katie, who will share a new development of a tool around iPrism, and I will not say more there. I will let her reveal the surprise. And then Samantha is going to share with you how you can learn more about PRISM as it relates to the reaim.org web tool, which we have been working on for the past several years. And I apologize, I had a little message here that we wanted enabled subtitles. Wonderful. And then Paul will take over, and we will try to leave time for Paul, so we will get through here. So what is PRISM? Most of you on the call, I assume, know PRISM. And so I would like to encourage you during this session to use the chat for comments and questions. Please do put in your name and affiliation. Who is here would be good to know. And then if you could also share your experience level with PRISM. Are you familiar with it? Have you used it before? But those of you who are newer to PRISM, it is, again, the practical, robust implementation and sustainability model. It was first published in 2008 by the publication I'm listing on the bottom of this slide by Feldstein and Glasgow. And it was created in the context of a healthcare system innovation around actually colorectal cancer screening improvement at Kaiser, using a lot of elements from the chronic care model at the time, but also other quality improvement concepts and implementation science concepts. It is basically the contextually expanded version of REAIM. It includes REAIM and it includes multi-level contextual elements. And in terms of the use of it, it could be used by the Nielsen categorization as a determinant, a process, and outcome framework. So it's really a multi-use framework that can be used in different stages, pre-implementation, implementation, and sustainment, and also for different purposes. In terms of the connection between PRISM and REAIM, again, is that PRISM is not a new or different framework. It is actually a framework that expands REAIM with contextual components, as I mentioned before. It includes both the PRISM contextual domains, which are multi-level in nature, and you will see a little bit more of these and different variations on this original figure in the later slides. And then also the original REAIM outcomes. So when you mention PRISM, you already assume that you are talking about REAIM and contextual domains. You don't have to say PRISM and REAIM. And the two components interact with each other in an ideal context, where you will see the contextual domains influence REAIM outcomes. And as you will hear it in the review, that piece of connection is still evolving in the literature. Very briefly, recently we published this citation analysis and scoping systematic review. It is in implementation science. And I would like to acknowledge all the co-authors on this publication listed here, who have been wonderful in getting through all the papers that we found that used PRISM and then abstracting information about it. The key goal was to see where PRISM has gone since 2008. So we were looking at the literature between 2008, the original publication, through September 2020, so not the full year of 2020. And we were trying to identify any paper that either cited the original PRISM publication or met a certain search criteria. And that's kind of was our main search approach to get the papers that we included. And then we abstracted information both about the study characteristics and the different PRISM domains, both the PRISM contextual domains and then the REAM outcomes. And we looked at how well they were operationalized or how they were operationalized. One interesting twist that I wanted to stop, and it seems a little bit of a segue, but I think it's kind of a good discussion, is how we decided of the use of PRISM in the different papers. And this is based on a prior publication by Field and colleagues, where they looked at the use of another implementation science framework, and they identified these different categories. We found this helpful because PRISM was not always used in the traditional way of in a study, in an individual study, but it sometimes was used in other manners. Sometimes it was used to frame a field, for example, shared decision-making, or work that actually Katie was doing in the context of introducing informatics in healthcare systems. In other cases, it was part of a review. Sometimes it was just referenced in early or late parts of the paper. Sometimes it informed certain activities or directed designs. And then the part that we were most interested in is, of course, the integrated use, when it was carried through in the planning, design, and delivery of the intervention and the evaluation pieces. And so the most information we gathered is in this category of integrated. And then we found that some of the papers we identified were not actually using PRISM, even though they came up in the search, so those were excluded. So when you look at these different categories, here you can see our PRISMA figure, you will see that we found a total of 180 papers that included PRISM in one of those manners that I mentioned. Of those, we found that there were 32 papers that used it in an integrated way. Some papers published on the same study. So once we combined those papers, we had 23 unique studies. And so that kind of was the basis for our in-depth analysis. And then here you can see, just to kind of go back for a moment, still all the different publications, that the number of publications that included PRISM in one or another manner increased over time. And you can see that there is a good portion that is using it in a referenced manner, and then there is some increase in the integrated use of PRISM. We are also aware of additional papers that came out since this review that were not timely to include, but we know that there is, again, an increase that we are aware of, at least. And then in terms of the use of PRISM, and now I am referencing only those 23 unique studies, you can see that there is a variety of use of PRISM in these studies. It was primarily used in high-income countries. These publications were in those types of settings, and then clinical outpatient settings. There were some community settings as well. And in terms of the types of use, you can see here that evaluation, planning, implementation, all are pretty common uses of PRISM. Some used it for sustainment and very few in dissemination. And then when you look at the operationalization of the PRISM elements or the context domains, you can see that there is a variation in how many of these are being used. There were 6 studies that used all 6 PRISM context domains, and the rest used some combination. And then you're looking on the right, you can kind of see the types of operationalization approaches. Most common was qualitative approach, quantitative, and then multi-method and mixed method. So there are just different ways that these studies think about how to put PRISM into work. And then in terms of the REAM part of it, right? Very interestingly, only 6 studies reported on REAM of these 23. So when people looked at PRISM and used PRISM, they primarily operationalized the context domains and often forgot about the REAM part, which was very interesting to us because we were thinking REAM is more known. That would be a natural thing that gets operationalized. And if you get into the details, only 2 of these 6 actually connected in some ways the context domain with the outcomes. So there is a lot to be done there. These are some key findings. Let me see if I can move the pictures here to be able to see you and the comments. It's a little bit of a trick here. Anyways, I will just highlight a couple of these findings. I already mentioned that the primary use was in outpatient clinical settings. There are some community use, but I think that that's certainly a direction we could go. There are a variety of issues that are being addressed and conditions through this review, and you are welcome to reference the paper for details and the different designs that these different studies followed. And as I mentioned earlier, there were 6 studies that used all PRISM domains, but there was half or more of the studies that used at least 5 of the 6 context domains. You can see the most frequently reported PRISM context domains, and then the most common implementation and maintenance being the most common REAM outcomes. But I will just move on here, and you are welcome to ask questions if there is any interest. Sorry, I am.
Porshika, I saw there was one question that I thought you might want to respond to. An excellent job on getting through this so quickly and concisely. The question was, can you talk a little bit about pros and cons between using PRISM with REAIM outcomes versus using REAIM with other D&I models?
That is a fantastic question. I'm sorry, I also fixed my technical issue. That was perfect. My preference of using PRISM context with REAIM outcomes, and if I understand correctly, the question is using REAIM with PRISM versus REAIM with other context models. Is that, Paul, the correct?
That's it, yeah.
Yeah, I think that, you know, what we saw though, but the idea is that PRISM connects naturally with the REAIM outcomes. That's how the PRISM context domains were shaped. And a lot of the thinking that Russ and others have done in the past is connecting these 2 components in a natural way. Of course, many people have done the same thing with CIFAR or EPIS, that they took CIFAR and EPIS and then they connected to REAIM, but PRISM was designed as a compact package, so you have it together. I do like PRISM generally because of the relative simplicity compared to some of the other complex context models. It is intuitive for many groups that we have worked with, and the fact that it acknowledges these different levels of partners is just really powerful. I love that, and we have tailored it to the different contexts where we work, so we name the different groups according to the local context. So I just find it really intuitive, and for that reason, I enjoy using it. But I think that you can do similar connections for other models. I don't know if anyone else would like to jump in for additional advantages.
Just maybe one quick one. This is Russ. Most people today have used, when they think about it, just the REAIM outcomes portion of PRISM, but we do encourage the overall use because we think tying the context is critical. I will just say, though, that while a lot of people do use PRISM, or I think particularly PRISM or EPIS these days, it also is possible, if people wanted to kind of flip that and use the PRISM models of contextual factors with something else, like the Proctor outcomes, or as many of you know, there's a new set of outcomes in CIFAR 2.0. Paul has expanded a little bit, some other models. So you could kind of turn that on its head too. All possible. We generally feel, just because it was developed that way and kind of synthesis, if I let Borsika get to her other point here, that it makes particular sense to use the as an integrated whole, but it's possible to do it otherwise.
Thank you so much, Russ. Yeah, that's an interesting idea. That would be fun to discuss further. The general recommendations we made in the publication are outlined there, and I think that we have better use of today's time, but I wanted to highlight just a couple. I think that understanding quantitative measures, especially for the PRISM context domains, will be critical as we move forward, and I know that we have a number of colleagues working on this actually. I did want to bring up this idea of standardized definitions. It just came up in our work recently, and I had a separate help email sent out to our group around using PRISM for coding interviews and thinking about the meaning of each PRISM component and making sure that we have a very clear operationalized definition around those. And then whether those definitions are used consistently across studies, that would be another layer there to kind of explore. And then as Russ mentioned it actually, and it came up that sometimes not using all the components of PRISM is okay. You know, we already said this with REAIM, that not all REAIM dimensions might be important in a given study. You want to acknowledge them, but you might not measure them. Same thing true with PRISM. I would add that PRISM, it's also important to think about how it might be different across the different time points. So as you go from pre-implementation, implementation, and sustainment, how these different contextual domains change. And that is very well described in the EPIS framework. It is true here as well, that over time, these components might change. Reporting, we talked about already. I guess I am going to jump here because I would like to get to Russ, but there are a number of ways that both researchers and implementation partners could think about taking advantage of PRISM. And again, as I mentioned, we have a number of current studies where we are trying to do that. We are adopting, we are tailoring, and so hopefully you also reflect on that in your own work. With that, I am going to slowly transition over to Russ.
Thank you. Let me take myself off mute. I'm going to very quickly walk you through a work in progress, and I want to emphasize that. We would love your feedback here, but we're have just been stimulated to think about how we can use PRISM with both of its aspects here to address health equity. I want to acknowledge several people, many of them at the listed at the bottom, but others, including some of the others of you on the call here, but especially Meredith Fort and Spiro Manson. We're working on a paper led by Meredith now, just about to submit it, but it's still a work in progress, and we would love your feedback as well as on the general thoughts, but as well as the figures that you're going to see in a moment. So please let us know what you think. Next slide, please. Okay, this is the first and the last slide I'm going to show you here, but I just wanted to set the stage and kind of have you think about this as I go through, I think, about 5 or 6 other slides. This shows a different way of looking at PRISM. Kind of everybody's a little different, more of a vertical way where you have, as you've seen, just the PRISM contextual factors at the top, Borsika's described, goes through from a D&I perspective, talks about the intervention, the implementation strategies, and then the REAIM outcomes. So hopefully that might be another way of thinking about conceptually. In the left and the right-hand side are specific actions that can take, we feel, using the model to try and enhance equity. And I'll be giving you a number of examples, but we'll return to this later. Next slide. Okay, quick review here, going around from the bottom left clockwise. Multi-level context are critical. I think we'd all agree with that, as is participation. And we want to bring up a term and make a differentiation between 2 similar concepts or words: representation, which means who's at the table in terms of the planning or the evaluation. Who is this group that's with your implementation partners, your advisory boards and stuff? How are they involved throughout the different phases? At what level? Going up to the top left, again, from its earliest outset, REAIM and now PRISM have really attempted to enhance transparency and translation. Top right, as you know, and I will give a couple more examples, this issue of representativeness and on different dimensions and in different factors is critical and applies at all aspects of REAIM, not just outcome, not just reach. And then we could do the next slide, please, Borsika. This is kind of a thought or maybe takeaway piece for you, particularly the underlying features there. But I think I've already mentioned that you can think about PRISM at all steps of an intervention, all stages and across all the outcomes there. Again, in the center top, this distinction between representation, who's a member of the team, in the community, and are those really have all the key people that you need, including many who are historically left out or excluded, and then the representativeness of the outcomes. You'll see many systems issues, and we also think one of the ways that PRISM can be used is to help about unintended consequences. Maybe the takeaway in my last slide today on the bottom left talks about how PRISM can be used to help guide adaptations to doing that. I think that's one of the most exciting areas, and hopefully we'll have a little chance to talk about that. The bottom right, finally, is just this notion that we can combine PRISM with not only other theories, but with other methods too. And there's a slight prize or pop quiz here about whoever can get all of these acronyms right at the end of the presentation. Paul will write you a check. But I will just mention maybe the most obvious one is there at the top, is that we feel importantly to be using PRISM to design for dissemination. And nowadays we like to say dissemination, sustainability, and equity. Next slide. Okay, this one I think I'm going to skip because Borsuk has covered it. It's just a reminder here about the critical importance of dynamic multi-level context. And then at the very bottom there, this notion of implementation and sustainability infrastructure, from my perspective, is the aspect of PRISM that might be the most unique or different, than the 20 other models of context. Next slide. Okay, going to give you a very quick example of some of the ways that PRISM can be used. This was on a study a few years ago now, led by Gary Bennett and colleagues, also involved Karen Emmons, Graham Kolditz, Deb Ritzwaller, myself. But it was a weight loss intervention to address both weight and hypertension control that came out of Gary's great work on weight loss, and particularly focused on African-American populations. As you can see, this was a largely African-American, low-income population delivered in English and Spanish. The context was this was 3 community health centers, FQHCs, in inner city Boston. So some of the ways that we used PRISM in terms of doing that was this first issue of engagement of different key partners there, clinic staff, decision makers who would have to decide whether this be continued or not, certainly patients, in not just planning, but evaluation there to address this local inner city Boston FQHC context with low resources. That kind of addresses the second one too. We're trying to think about how to make this easy, low cost, low burden for the staff, and also like for patients to come in, instead of having to come in for additional visits, this was part of a regular primary care visit there. And last point is probably obvious. Next slide, if I can. Okay, so again, this notion of adaptations is important there. Both maybe especially at the outset and the planning stage to make this culturally appropriate. Also did things like tried to really have very low literacy level, a lot of use of graphics. Certainly the food recommendations and examples were tailored or targeted that way. One interesting thing is we also found it was really important to let participants, it started out with a web-based session, but participants were given their option of different ways for follow-up contact. Most behavior change things important. They could either do a fairly transparent web-based, or they could have phone context or follow-up. There was an automated phone option. This was a little before text was big, so we didn't give text, but this was really important. We found that people use different follow-up modalities. Our outcomes, again, we focused across them on multiple dimensions, but at each one focusing on equity there. Very briefly, so I can get to the take home, we had reasonably positive results, like everything, good news and bad news, but we thought pretty high reach of all patients that came in. We did have significant but modest effects on both weight loss and blood pressure. One encouraging thing was the individual level maintenance or sustainability maintained out to 2 years. And then also maybe most encouraging is that there were no moderator effects there. The intervention seemed to be robust across at least a limited number of factors that we had there: race, education, income, and gender. Next slide. Okay, we're going to return now to this model that I talked with you about, which shows PRISM context at the top, intervention, implementation, and then the re-aim outcomes at the bottom. But let's take a quick look through, starting with the next slide. On the left-hand side, some specific options that can be used. I illustrated some of these. First, top left, let's work our way down. Multi-level context is critical. As Borsika said, that can change over time. The notion of co-creation, we think, is really critical, and fit. It's important, and we want to emphasize here, it's a little hard to show graphically, but fit is not just thinking about context alone. It's not just the intervention, and it's not just the implementation or delivery strategies, but it's all of these things that need to work together or be integrated. A point in the re-aim outcomes going down here that we'll come back to a couple different ways, but is really important and a little bit nuanced, is that the re-aim outcomes are not independent. They're conceptually distinct, but you need to think about systems issues. I'll come back to this a little bit later, but often doing one thing to emphasize one can have some unintended consequences on the other dimensions. At the bottom left, certainly cost is a big issue, particularly thinking about not only individual recipients and community members, but also settings, and particularly if we want to get into many of the settings or the places that people are, we need to be very low-cost, feasible interventions. Next slide. I think I'm going to, so I don't run over my time, going to move along here quickly. Oh, can we go back just one more point, Borsika, before I say that? And that's this notion of, at the right-hand side towards the bottom, representativeness and equity are critical across all re-aim outcomes. I want to say that again. We can talk about it. It's not just reach, which people kind of get today, and encouragingly, but they don't often understand that we also need to really focus across all these other outcomes, and particularly so we don't have unintended consequences. My last slide here, as we transition to Katie, that I want to end with is, again, using a slide that Borsika and I like to use to think about all the different ways you can conceptualize and different types of adaptation here, are that PRISM can be used, okay, to focus on adaptations to, going down the left, the intervention, the implementation strategy, or the setting, and they can be used very productively across the life cycle of a program, not just during the planning. With that, I think it's over to Katie.
Excellent. Well, continuing our lightning speed tour of all things PRISM to date, I'm going to introduce iPrism Web Tool, which is an interactive guide to iteratively applying PRISM and re-aim. I will probably mention re-aim at certain times, but when I do say PRISM, I do mean PRISM and re-aim. And this is intended to be across the life cycle of a project. And Mustafa, to your excellent point, the goal of this, one of the overarching goals, is to make PRISM more approachable, easier for different audiences to use. And so by using this tool, our intent is it helps people operationalize and use it. And this will be available in both English and Spanish. Before I provide a very high-level overview of the web tool that's still in development, I want to provide a little bit of background. And one of the drivers for this web tool is we need to move faster in order to get evidence into real-world settings. And when we look at D&I frameworks historically, they're often used in the literature. But they're infrequently used throughout the life cycle of a program or project. And so when we think about the life cycle, we're thinking about pre-implementation planning, we're talking about during or implementation, and we're talking about sustainment or evaluation. Most often, historically, these D&I frameworks are used for either planning or evaluation. And when you think about specifically REAIM, it's prolifically used for evaluation, and it's certainly used successfully for planning as well. But when you take a broader look at those different models and frameworks that are out there, they're really not used iteratively to guide adaptations at key points in real-world projects. And this is a misalignment between what our implementation partners need. They need us to move faster. And so that led our group, largely Russ and Borshika and others, to really put into practice iterative REAIM, which has been around longer. And so when you think about how iterative REAIM has been used, next slide, please. There's some key lessons, challenges, and future directions of iterative REAIM. So to date, iterative REAIM has been used successfully, and it's been found to be feasible across really diverse settings, situations, populations, content areas, and successfully with teams. And in fact, really iterative REAIM can be a method to really promote team discussion, reflection, and action planning. So really that co-creation piece that Russ was talking about. Certainly in the experience of using iterative REAIM, there have been some challenges. Notably, a challenge that we all face in our work is availability of reliable, timely, actionable quality data, especially when it might be more subjective and less objective in nature. And certainly trying to figure out the right number of iterations and the level of facilitation needed to guide teams through the process of iterative REAIM. And certainly, as has been discussed, you can't really think about impact and outcomes of REAIM without thinking about the context. And so to date, there hasn't been a formal way of integrating the PRISM context issues with iterative REAIM. So these findings, these lessons, these challenges lead us to our next steps. So next steps include continuing to apply iterative REAIM in different contexts and situations. So specific examples include global health hypertension and lung ultrasound in hospital settings, and use of real-time electronic health record data and scheduled biweekly meetings for rapid iterations. So pretty exciting, overcoming some of the challenges that have been faced in the past. And notably, formalizing a way to do iterative PRISM. So not just REAIM, but integrating the context of PRISM as you go through the iterations. So that takes us to the PRISM web tool. So this is just a very high level overview, and I absolutely cannot have enough time to share with you some very important details, but more to come, and I'll share with you how to get more information. What you're seeing right here is our homepage for our website. And there's a lot of information on it, and this is just a snippet of it. It certainly gives the user an idea of what to expect, links to more information, but prominently placed is a Get Started button. So if we were to hit the Get Started button, it would take us to our next slide. And here it breaks down what the user will go through. And it's largely 4 different steps that a user will follow when using the web tool. First, they will indicate whether they are completing this as an individual or as an individual as part of a team. And that's important because the web tool is going to store the data differently. If you're an individual completing as part of a team, it will later collate your team's information and summarize it nicely for you. The second step is answering some questions, some general questions to get you thinking, but specific questions to operationalize the PRISM framework. And then it will summarize in an automated fashion your results for you and prompt you through the process of identifying ways to improve your program's alignment and impact. So next slide, please. So after you have indicated whether you're an individual or a team completing this, it'll ask you what stage of your program are you at. So this is intended to be used iteratively within each of these stages and across these stages. So you would indicate the stage of your program, and then depending on the stage of your program, you're asked a series of assessment questions. So next slide. And these assessment questions are really the bread and butter of operationalizing PRISM. And so this is what makes the PRISM framework actionable. And I want to point out that throughout these assessment questions, they get you thinking about representation and representativeness. Equity is throughout this. To operationalize the 5 different dimensions of REAIM, there are 15 questions, followed by a subsequent 6 PRISM questions for the 6 PRISM domains. Next. And this just gives you an idea of how these assessment questions are laid out and what a user would do. So excuse this, it's not fully formatted appropriately yet, but it gives you a sense. And what I want you to focus on is, this is REAIM. So this is a snippet of the REAIM assessment questions. And it asks you, how likely is it that your heart failure CDS program will be adopted by a high percentage of intended settings? Note that it has heart failure CDS. So earlier on, which I didn't show you, is it asked you the name of your program. So to try to make this more relatable, one of the ways is that it'll dynamically update your team name throughout this. And then based on these prompts, a user will indicate how likely it is that they meet these different criteria. They also have the option to select not applicable. And if they so choose, they can jot down some notes that they can go back to later. So this is just an example of what it looks like as a user. Next slide. Once a user has answered the series of 21 questions, their results are automated and summarized for them in visual displays and graphical displays that allow the user to quickly look and see, oh, this is an area where I could make a change to improve alignment or impact. And these displays are tailored to the individual and or the team. So it will summarize each individual of your team's responses. I'm not ready to show you the team visual displays yet, but I can share with you an idea of what the individual graphical displays are. And that's here. So after answering these assessment questions, this is what an individual would see. On the left are their REAIM scores. And remember, each the 5 REAIM dimensions has between 2 and 4 questions. So if a user were to hover over the different areas in the REAIM, they would see what the individual questions are, but without hovering, they're just seeing the mean scores of the questions in that dimension. On the right are the PRISM scores, and 1 question per each of the different domains, but they can also hover to see the details of the questions. Notably, export, so people can print this information. And so greater color represents areas that need less improvement. You're doing really well. Less color towards the center represents those areas where maybe we need to spend more time. Based on these results, a user will then, the website will then guide the user, next slide, through the process of identifying feasible and impactful implementation strategies to improve, and guide them through the process of developing concrete action plans. Next slide. Ultimately, to help guide and nudge users to identify these implementation strategies and decide which ones to actually implement, the web tool will create this nice scatter plot where on the x-axis is feasibility that a user indicates, and the y-axis is the impact. And within there, you can see there's 3 different implementation strategies: integrate within clinician workflows on the top right, audit and feedback towards the middle, and the bottom left, decrease patient out-of-pocket cost. And so the graph here pushes them to prioritize doing those in the upper right quadrant that are highest feasibility and highest impact. And then they can also print this slide. More to come, so we can go to our excited slide. Early Christmas time. This is our Christmas present. We aim to have a publicly available web tool, and we would love your feedback. Many of you have already provided a lot of great feedback. We will continue to iterate on this web tool. We are going to be presenting not just this web tool, but also our body of work around iPrism as a method at the NIH Academy Health D&I meeting, Tuesday, December 13th at 2:30. And this web tool will be available at a booth outside the meeting rooms for demos, Q&A. So anyways, we'd love your feedback. Please reach out if any of you want to test this out. And with that, I'm going to turn it over to Borshika.
Thank you so much, Katie. Katie, I have one question for you, for Amber. Is there going to be a profile that people can come back to, that they can save their work? So I wanted you to address that.
Very important question. So we are thinking about these things before you hit submit on the website. You as an individual can go back in whenever you want. Your work will be saved. Once you hit submit as an individual, you cannot go back in and edit your responses. Again, it's trying to encourage you to do this iteratively over time. However, there is a unique code that teams will be given. So that will link in the background your individual response with other teams.
Thank you so much, Katie. Before I hand it over to Samantha, I wanted to let you know that we have already plans to come back and talk more about PRISM in some other way. And that is going to be through our December REAIM webinar, which is planned for December 8th at our usual time, the same time. And it is going to be presented by Dr. Rebecca Guerin. Dr. Guerin is the Chief of Social Science and Translational Branch at NIOSH, and she will be talking about how she has been integrating implementation science at the National Institutes of Occupational Safety and Health using a PRISM lens. So PRISM will come back. And with that, I'm going to stop sharing, and no, actually, I'm going to go to the next slide and hand it over to Samantha.
Hi, everybody. I'm Samantha Harden, and I'm so glad you've been able to join. And of course, for anyone watching afterwards, one of the biggest places that you can find our information is at re-aim.org. And of course, this kind of leads back to our image issue of we're saying it's REAIM, but here's PRISM, and I'm going to show a little bit about that. But this has been the website since the early 2000s. And so we have a lot of traffic and a lot of ability and a lot of familiarity with this website. So this is where you will get information on both REAIM and PRISM, because as we all know now, they are interrelated. And some of the things that I love the most about this website are a lot of our tools and resources. If you are an instructor trying to introduce REAIM in a classroom, there are PowerPoints that you can download and tailor for your group. If you are introducing REAIM to a new community or clinical team, you can, I also said REAIM, when you're introducing PRISM to your new community group or clinical team, there's so many different resources, and I'm going to share screen in a second, but those brief explainer videos are 1 to 2 minutes. You can integrate them into your PowerPoint slides. You can watch them yourself, or you can share with others. There's, of course, frequently asked questions and some examples, guidance on the application. And then, of course, in the right-hand side of the entire website, you can do a lot of searches. Some of the things Dr. Strayer and I receive in terms of questions are, has REAIM been applied in, and then fill in the blank. And of course, you could find that through your typical PubMed search, but you can also find some additional resources on the website. And so taking us to the website, it is re-aim.org, but what I want to highlight today is that you might be more familiar with what is REAIM and then the drop-down list by dimension, but we now have what is PRISM and then drop-downs based on all 6 domains. So you can hover and then click to any of those, and then they will provide guidance in terms of what is intervention characteristics? How is that operationalized from the organizational perspective and the patient and community perspective? And then, of course, some additional information at the bottom of each page. So that exists for all 6 domains under our Learn. I will also go back to the home screen because one of my favorite videos is this brief video over here of 4 minutes of how REAIM and PRISM fit together. And that might help you really articulate in your grant proposal or your paper how you're trying to introduce this concept that we've been spending the last 46 minutes to share about how PRISM is an expanded version of REAIM. So after you've learned all that, or after you perhaps are teaching and facilitating understanding all that, you can also go to apply. And just as we've had REAIM guidance for over 15 years, we now have PRISM guidance or assessments as well. And you can scroll down, hover, and then come over to PRISM assessments. This, of course, as all science is a work in progress. So we're providing things like semi-structured interview guides and updated validated questionnaires and things like that. As the science emerges, our goal is to make this open access for you. And one of our biggest values and mission is that this is bi-directional. So if you're going to the website, can't find something or need something, please email us, because I hope you get the level of enthusiasm that all of us have, the level of work that we've put into continuing to update all of our information, and you are the reason we do it. So please feel free to reach out and say, I need this resource, or have you thought about this, or share your resources with us, because as dissemination implementation scientists, we never want to reinvent the wheel. So let's continue to have our conversations together. And I look forward to seeing you at our next webinar, but don't go anywhere yet. I'm just saying I'm excited, and I'm going to turn it back over to Paul.
All right. Well, thanks, Samantha. And at this point, we're just going to open things up for questions. I'm going to look, I think most of our chat questions were already responded to. So I'll just remind folks, if you have a good question that you'd like to put in the chat, that would be great. Maybe I'll just start as I'm waiting for some. Borshika, one of the things that I've talked about with you before, that I'm curious with the way that you've been applying PRISM is, how might people who are trying to do this in community settings, outside of healthcare settings, apply PRISM? Are there different strategies that strategies is the wrong word, but are there different methods that you might propose for folks that are doing work in community versus healthcare settings where most of the work has been to date?
Thank you so much, Paul. As I mentioned in the review, most of the work is truly presented, at least the ones that are published on. And we know from Bethany Kwan's work, where you look at non-published literature, there is much more going on under the kind of the water, but is in clinical settings. I think the key piece that we found in some of the work where we used PRISM and it was more community settings is the language. We have to make sense of these domains in a way that it's meaningful to the community. And so sometimes it's about what does organizational characteristics mean in the context of the community that you work. It might be a multi-layer concept there as well, and they will be very much experts in telling you what those layers will be. And it is a good idea to adopt. We have an adaptable or tailorable version of PRISM, so email us, and actually Brian Ford is the owner of the highest resolution version of this. And then you can make those changes. So when you present about it with your partners, one of the key examples that Rebecca can speak to in December is the use of PRISM in the context of the school system in Miami-Dade School District. Yes. And the language of how we describe that organizational characteristics, or the patients, which are not patients in this case, right? Right. That I think is the key piece. I do think that PRISM is intuitive in the community context. Once you make those changes of language, there is an immediate connection, and people who you work with will be, again, the experts in telling you what should be on that figure. You don't have to know that, and you will not know it as well as they do. So I think that co-creation of the revised version of PRISM for the context is important.
Oh, that's a really good response. And I'm kind of looking to see if I've got other questions. Of course, you guys know I always have lots of questions. So when you talked, Borshika, you gave me a nice transition. Co-creation was mentioned by you, it was mentioned by Katie, and it was mentioned by Russ. And so, and I'll open this up for Russ or Katie, whoever would like to respond to this one. How do you go about, if you're somebody that's kind of new to this type of work, how do you go about initiating partnerships to develop processes for co-creation?
Well, I'll start and see if I can punt this one. Actually, Monica, I'll give you a quick shout out here. I may actually turn this to you briefly, but let me start answering, then tell you why I mentioned Monica. We're fortunate to have on today. I think the notion starts with this representation, and that's kind of who's at the table to begin with. But it's also, I think, the process that's involved there and how to present things. And I think one issue of that is when you have an evidence-based intervention, which, you know, many of us say that's the starting point for implementation, how do you present that in a way that there is something there to build on, but this is not like something that's going to be imposed on you, that's set in stone. And the issue is, I think, especially, how can we maybe, sometimes the word is co-refine, okay, involved, or co-adapt this or whatever, because many times you're not totally starting, you know, from zero there. But I'm very much learning on this. And if she can be unmuted, our colleague, Monica Perez-Yales, who has just joined us at Colorado not long ago, has done a lot of the work and thinking about this far more than I have. So maybe if, Monica, if you can be unmuted, and then if any of the other panelists have anything to say.
Yes, good morning. And pardon that I don't have
Good
video.
morning.
I have a terrible cold, so I'm actually joining from bed, but I'll do my best. Yes, I am very interested on unpacking this concept of co-creation, because there are many definitions, and I think that's important for us to define. How do we define co-creation? What do we mean by co-creation? Quite often is mentioned, and they are not definitions or concrete ways to capture that process. I like a couple of definitions. One is all of us partners set the direction of the development of whatever we are engaging in. So the direction itself is built upon each of the interactions of our partners. And the second, by Greenhall and colleagues, is building knowledge. How do we build knowledge that includes our expertise, professional, academic, and lived expertise? So I've been exploring this concept of co-creation, thinking in terms of a dynamic process. And to answer your question, how do we start engaging in partnerships from this lens? I would say, looking at what are the goals of the partnership and seeing the partnership as part of this PRISM context. That's part of a strategy and as an intervention. So what are the goals of our partnership at the beginning, knowing that they might change, and what concrete activities are we going to pursue? Are we going to engage during the engagement process to reach each of those goals? And what do we expect to gain at the end? What will be the outcomes of this partnership? So I think a focus on the partnership itself in terms of what are the goals, what are we doing about it, and how do we link it to outcomes? And I was talking to Bethany yesterday, great conversation on doing it a kind of repetitive way when we constantly check on that co-building of knowledge or setting the direction of the development. A baseline before we start engaging, perhaps right in the middle point, follow-up. But certainly this is still an area that where we need to unpack what we mean, how do we define it, and how we measure it. And I'm working with some colleagues, including Russ and Bethany and others, on how do we measure, what will be the best way to develop a tool or a measure of co-creation within the implementation process and engagement process.
Paul, you're muted. You're muted, Paul.
I don't know how I did that, but probably complete user error. Yeah, that was an excellent response. Thanks for that, Monica. I think that going through the idea about definition and process, I think is really important. And I'll throw out a plug for the stuff that Samantha and I have been doing over the last 15 years related to integrated research practice partnerships as a strategy to do co-creation of both implementation strategies and evidence-based interventions. So I think there's things out there, and I also think community-based participatory research is another way that we can engage folks in this co-creation process. But I think it's been being done for a good long time, but we just haven't been characterizing it and really being able to show how we're advancing that type of science. Okay, let me, I'm looking like I'm getting a couple of chats in there.
Paul, I can just very quickly, while you read
yes,
those, pull out
please.
Mustafa's comment that I know that Mustafa has a very extensive experience with this design and co-creation in his own work. And he mentions that an effective strategy process for co-creation could be hands-on workshops. Design community is pretty advanced in organizing these workshops. And I'm thinking implementation workshops similar to design workshops, but focusing on implementation issues. And thank you so much. I think the key of bringing in the design, but the design community already figured out in decades, would be critical. And I know that we are still learning.
Sure. Excellent. Okay, I'm gonna just scroll back up. I thought I saw a couple of questions earlier on that, and this one might be back to you, Borshika, but it was a question about when you're talking about the simplicity versus depth, like when you talked about PRISM being, it has some level of simplicity in understanding and application. And so there was a question earlier on about, what's the,
Yep.
Where do you have that balance between simplicity and depth?
Thank you so much. I am sure that we could take this question in many different ways, so I will take it one way that suits me today. The notion of, I think what I was trying to suggest is that PRISM's number of constructs is a little bit more limited than what you would see in EPIS or CIFAR, for better or worse, but it does create larger buckets. And then once you have those larger buckets identified, we do get into subconstructs. In fact, the recent interaction with Paul just reminded me of the subdomains of PRISM that exist. And so when you go to the original publication that outlines these the most beautifully, the Feldstein Glasgow paper, there are a number of very complex subdomains, but if you are able to start with relatively small number of large concepts, and then you allow, again, the context to define what the subdomains are, it just allows for more interaction and co-creation from my perspective. But of course, I have colleagues who are master users of CIFAR and EPIS, and they could provide a similarly explanation that would decrease the complexity of their model. So I don't want to say that they are overly complex, but PRISM for me has enough complexity and enough simplicity.
Excellent, thank you. And it's almost like you could see the time. We are at the top of the hour. And I just wanted to say thank you to all the presenters today. I think that Russ, Katie, Samantha, Borshika, excellent. Dr. Glasgow is using his privilege to say he would like to have one final summary comment.
I already did, Paul. I just said all of these are work in progress. So please give us your constructively critical feedback. Okay, we need this. Next steps for research on PRISM, the equity model and figures, and certainly the iPRISM thing. We'll look forward to seeing many of you in December.
Excellent. Thanks, everybody.